first of all, I'd like to thank you, Jerry, for that introduction, and to Dr. Michiguera for inviting me here. Okay, we've heard a lot this morning about treatment of keratoconus, the Athens protocol, ocular wavefront treatments, the AMARIS protocol, and this is more or less, but with a slight twist. This 26-year-old male had progression despite a carrying implant in his left eye. Performed a corneal wavefront guided transplant with volume reduction in ablation, and we ended up with that. You see here the planned ablation protocol and the difference map are nearly identical. Basics, and talk about the goals in treating keratoconus. Now, cross-linking is a valid option for progressive keratoconus, of course. Increasing biomechanical strength and arrest of progression, of course, and improves corneal irregularity by improving the anterior corneal steepening. Anterior surface normalization procedures, whether it's topography guided, or corneal wavefront guided, or ocular wavefront guided, have been numerous to recite in the current literature. The improved topographic or tomographic refractive outcomes through these procedures, and we have seen long-term results and stability in long-term of such treatments have been shown in large cohorts of patients by distinguished colleagues such as Dr. David Lin and John Kanellopoulos. Variations of such treatments have been shown globally. A topography or a wavefront derived ablation step does require a very, very high degree of customization. The effective alignment of this data, derived data, and the ablation pattern is thus extremely pivotal. Now, the competition now has a cyclorotation tracking capabilities with the topical laser Vario, of which we've had for more than the last 5 years. Not only that, but horizontal and vertical eye movements and pupil centroid shifts and cycle torsion needs to be compensated. In other words, DCC, asymmetric offsets that the competition does not have. The AMARIS has all these capabilities. And not only that, but introduced this morning by Dr. Bruce Allen, it has minimization, ablation depth capabilities from the manager, whether it's from the pyramid or from the refraction. We can select specific high-order aberrations to be treated, minimize the ablation depth that is planned or the volume that is planned, and treat only those high-order aberrations that are absolutely necessary. We can alter the refraction of the target. As Dr. Bruce Allen showed us brilliantly this morning, he was only treating ocular high-order wavefront aberrations and no low-order aberrations. We can minimize ablation depth or volume this way. Now let's take a look at the ablation pattern a little bit more closely. This is a customized ablation pattern for this kind of cone. Now notice that there is coma correction with reciprocal superior wing up there, right up there, and coma correction right there. And notice again that the superior wing here, shown here, has a deeper ablation, as shown in red, than the green and yellow ablation depth shown for the actual cone. Now that superior reciprocal wing will consequently steepen the valley in between the cone and the wing, like so. So you see, the coma has been neutralized, and by ablating in the superior wing in this way, we have increased the curvature in the valley so that the cornea is now more symmetric. Now, this is an important concept, I think, that we need to understand, whether we are going to minimize depth or whether we're going to minimize volume. Now, this is a pre-op corneal wavefront. This is the ablation pattern for this wavefront, and this is the post-op corneal wavefront. Let's just consider this ablation pattern. I'm going to turn it around 90 degrees. So this part is the superior cornea, this is the inferior cornea, and this is the ablation depth for the cone, and that is the wedge of the superior wing that is in reciprocal cooperation in the superior part of the cornea. Notice that the depth of ablation of the cone is less than the superior part of the wing. Now, if we minimize the ablation depth in the manager, whether it's refraction manager or pyramid manager, we're going to end up with an ablation depth that is too little to compensate for that coma. But if we minimize the volume, we're going to end up with less volume removed, but a deeper ablation, and thus we are going to end up correcting more coma. So, if we look at an ablation pattern that has a reciprocal superior wing, I think we need to remember to minimize ablation volume, even though the depth may be a little scary at first. It's the volume and the tectonic relationships. It's not always like this. Now this kind of ablation pattern, which will be quite effective. The minimizations intended for the high order and refraction to correction. This is an example of a 33-year-old male, keratoconus. That kind of ablation pattern ended up this, pre and post. Another example, fellow eye of another female, pre and post. You can see the much reduced coma. And another example here, coma ablations, reciprocal superior wing, regaining of corneal symmetry, and again and again and on and on and on. Now getting back to the manager. When we enter the manager, we always look at the pyramid and the refraction. In the pyramid, we need to minimize the unnecessary ablations that are required to correct the unwanted high order aberrations from this eye. And we minimize volume, or we minimize plus volume in this kind of ablation. In the refraction manager, as Dr. Vinciguerra so eloquently showed us this morning, the current and preview and residuals are shown here. Now, we also want to minimize by volume, but we are governed by the constraints that have been programmed into the software. Now, these constraints are not rocket science. This is not rocket science. It can be 0, it can be 0.1, it can even be +1 for sphere, if you consider the effects of flattening after cross-linking. For cylinder, it could be 2.5, 275, the degree axis, it can be 15, it can be 8. Now, the constraints are not predetermined terms that come out from a multiple linear regression analyses. We're working on it. We're working down to reducing these constraints, finding special numbers, but we're not quite there yet. We need more data. So the constraints are important. Remember the goals of treating keratoconus. We are trying to regularize the cornea by correcting its coma so as to regain the cornea's symmetry. Optimal refraction, I think, is an important last step in the goals of keratoconus treatments. Dr. Bruce Allen gave us a brilliant talk this morning showing his intentions to correct only high-order aberrations so that the cornea could be symmetrical and regain tectonic and curvature balance. However, I beg to differ. Of course, the patient can wear glasses. Of course, the patient can have a better corneal vertex superiorly displaced now for a better contact lens fit. And after stabilization for a couple of years, of course, we could even implant a toric phakic IOL. However, what if we don't need to give those patients additional methods of correction? And I think the last goal for regularizing the cornea is to provide that eye with optimal refraction at the end. So, for astigmatism control in keratoconus, we have to remember that astigmatism is not directly governed by corneal toricity, but from the combination of this toricity and higher orders, especially coma, trefoil, and secondary astigmatism. Refractive astigmatism is further indirectly governed by spherical aberrations and offset. So, the way I see it, we have three ways to go around this. We can do minimizations with the refraction manager, as I've shown you today, or you can aim for a regular aspheric cornea with no high orders and toricity. We could just, this is a little different approach. Or we could do a non-wavefront guided ablation and aim for a clean manifest refraction. And of course, at the end of the day, that eye will have huge amounts of coma left, but his low orders will be corrected. A nomogram, I think Sam said this very eloquently yesterday, is something that we use to compensate for the things that we do not really understand. And because medicine should not be an art, but science, a balance between tissue removal and optimal refraction, I think, needs to be further worked upon. This quest for that optimal refraction after customized surgery for keratoconus, in the future, predictive modeling after customized ablations to show us the actual optimal refraction of that eye after customized ablations is something that we need to work on. This is a retrospective analysis of 48 eyes. We did with high fluence cross-linking with corneal wavefront guided surgery. Hurry. Got it. Uncorrected vision, BCVA all improved. So did cylinder and Kmax, coma, and even Corvus parameters increased after cross-linking. And that was only an ablation of less than 50 microns. So in conclusions, trans-PLK, corneal wavefront guided with pyramid and refraction manager minimizations in the software can help to regain symmetry with at least reduction of half of the original refraction. Refinements need to be made to constraints of the refraction manager. Thank you very much.